Good morning, everyone, and welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is Fiscal Year 2024 Hospital Inpatient Proposed Rule and Medicare Advantage Final Rules. Please note, this webinar is scheduled for 1 hour and 15 minutes. Thanks to everyone who submitted questions when they registered, as they helped us develop the content for this webinar. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you will be asked to complete a short survey and submit any questions. We will respond to the questions posed during or after the webinar via email. We have posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you will receive an email later today with a copy of the slides and a recording of the webinar. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Trevor. Good morning, everyone. So each spring, CMS posts a series of proposed rules with payment rates and policy updates for those prospective payment systems that operate on the federal fiscal year. Those include inpatient rehabilitation facilities, inpatient psychiatric facilities, skilled nursing facilities, and inpatient hospital. In a couple of months, CMS will publish a second set of proposed rules for those payment systems that operate on a calendar year. Those include hospital outpatient, as well as the Medicare physician fee schedule. PYA is in the process of publishing a series of primers that provide background explaining the operation of these payment systems, which are available on our website. But today we're going to take a deep dive into the FY2024 Inpatient Prospective Payment System Proposed Rule, or lovingly referred to as IPS. And in fact, Kathy, this is our third round of IPS as part of the Healthcare Regulatory Roundup webinar series. Very first HCRR webinar we did was on the 22 proposed IPS rule. Time flies when you're having fun.
I was going to say, we're still having fun.
Exactly. 24 IPS was released by CMS on April 10. It will be formally published in the Federal Register on May 1st. And comments will be due on June 7. And trust me, Kathy will tell you why. Oh, yes, dear?
I believe comments are due on June 9th.
June 9th. June 7th, June 9th. We better figure that out. We will post that.
During the course of this webinar, it will be confirmed. Because
there we go.
Our slide towards the end, Marty, is June 9th. And hold on, see how fast I can confirm things.
Okay, I'll keep talking while you're researching, okay?
Okay.
The final rule is going to be published sometimes in August, and it will take effect on October 1, 2023, which is the first day of the federal fiscal year 2024. So I'm going to turn things over to Kathy to discuss payment rates and related policies. Then I'm going to cover quality reporting, promoting interoperability, and the value-based payment programs. When we're done with IPS, our intention is to take a look at the 3 final rules that have been published this year regarding Medicare Advantage, and specifically focusing in on what is of interest to providers. So Kathy, tell us what they're going to pay us in 2024.
And comments are due June 9th.
Okay, June 9th.
Confirm that, so
okay.
Got that one down. So next slide, Marty.
Got it.
I wish I could tell you what they're going to pay you, but obviously this is a proposed rule. And we found last year that the proposed rule gave an update that was significantly lower than the final update that hospitals received. So we're hoping that we have success this year as well in terms of arguing why we should receive a greater level of reimbursement than we are getting now. And perhaps some of this background will help. They did propose an increase in the operating payment of 2.8%. That is using a market basket increase basket increase of 3% minus a 2% productivity adjustment. When we look at the market basket, what we are essentially looking at is a measure over time of the change in the price of a consistent mix of goods and services. So we're looking at the same products, but then we are looking at how they have changed prices or cost over a period of time. It's essentially a measure of inflation. They did use fiscal year 2022 claims data with fiscal year 21 cost report data. And as last year, we did have an adjustment related to COVID-19. We do not have that this year. Essentially, last year, they took claims with a COVID diagnosis and calculated a cost related to those claims, and then also did the same for those without COVID. They merged that data together. Now we are not making an adjustment for COVID claims. It is just straight look at all claims that occurred in 2022 and apply 2021 cost information. When we talk about applying 2021 cost information, we know what has happened since then in terms of staffing issues, in terms of the cost of goods and services, but recognize we need to focus when we're looking at the change in the operating costs, because we have the wage index that measures the changes in wages. We really do need to focus on the cost of the goods and services, the input prices going into the services we provide. One thing to mention that as we were looking at the breakdown in the calculation of the operating rate increase, it was very cut and dry of the 3% market basket minus the 0.2% productivity adjustment. Prior years, we have had an adjustment related to coding and documentation. We've had a number of years, I guess 2014 to 2017, where that was a negative number because they were actually recouping dollars that had been identified by the Office of the Actuary to have been overpaid. That was essentially when we moved from DRGs to MSDRGs. That was back in 2008, but then they took the reduction beginning in 2014. We have had a positive adjustment for the last few years. It has been a 0.5% increase in our rate based upon coding and documentation, but they have, as of right now, determined that no adjustment is needed for 2024.
So, Kathy,
yeah.
So when you look at that 4.3% increase for 2023, they have to credit that really as a 3.7% increase, 3.8% increase for comparison purposes, because it had it baked into it, that 0.5 adjustment, correct?
That's correct.
Is that right?
That's correct. For those hospitals that are either not complying with the requirements for the inpatient quality reporting program, Marty will go over those requirements shortly, but those who are not meeting those requirements, your payment update will not be the 2.8%, it will be the 2.05. For those who are not meeting the interoperability requirements, it's a 0.55% update. And if you are not compliant with either of the promoting interoperability or the IQR program, then you actually have a negative 0.2% update. So recognize that it is very important that you are not only compliant, but not only reporting, but that you are reporting correct data and are compliant with all of the requirements. One of the things that could have a significant impact on the final rule that will come out later this summer is that the information that CMS used to establish the inpatient rate increase, the 3% market basket, is that they use data from the third quarter of fiscal year 2022. But they are going to be using data from the first quarter of 2023 when they publish the final rule. They always use more recent data when they get into the publication of the final rule. Hopefully that Q1 2023 will reflect more of the costs that you are dealing with now, although I don't know that it will be as significant as those cost increases are that you are dealing with now. All of that added together, the base rate, the standardized amount that you will be looking at on a per claim basis that will be further adjusted by your wage index, but we're looking at $6,525 base rate compared to the $6,376 that we have for 23. So wait a minute, Kathy, that's a 2.3% increase, and you thought you just said, well, we get a 2.8% increase. It is other things that go into that overall operating rate increase in addition to the standardized amount change that ultimately reflects the overall increase in your reimbursement going forward. Capital payment rate, that is also going to go up for inpatients from the $483 that we are at now to a little over $505.
Okay, finally, 3 years after this, it's time for me to ask, why is there a separate operating rate and a separate capital rate for IPS?
Well, because back in 1983, I guess, it was effective for fiscal year 1984, so that would have been October 83. They only wrote an inpatient operating rule. They did not come along with a prospective payment system for inpatient capital until 1991, and that was phased in over 10 years. So we had a lengthy period of time that we got paid cost for capital, and we got paid a prospective payment system rate for inpatient operating. Then gradually, so that we are now with a operating payment and a capital payment. All of the other prospective payment systems, you get a single payment. You don't get a separate payment for operating and for capital. It's just that they were phased in at different times. The outlier threshold is expected to increase, and we would have expected to see an increase. I think it is fairly significant, going from about $38,860 to almost $41,000. So in terms of a claim meeting that cost outlier threshold, it will be a significant jump. We're going to talk about LTACs in a little bit. They are really going to see an increase, but there will be there is a proposed increase in the outlier threshold. Marty, next slide.
Maybe.
See how it works? Okay.
There we go. I got it. Yep.
We are not coders. We do not pretend to be coders. We urge you to listen to those who are in your HIM department in terms of the particular DRG changes that are going to impact your hospital. But just wanted to touch base on this issue a little bit. There are 15 new MSDRGs, and they're going to get rid of 16. Most of this falls under the diagnostic category for diseases and disorders of the circulatory system. They are consolidating a number of the existing DRGs. They are where a particular code would stand and group into one MSDRG. They are now consolidating a number of those so that we see the number of conditions falling under MDC-5 going away. I mean, the conditions don't go away. It's just all of the numerous DRGs that fell under that diagnostic category are being consolidated. This becomes an issue from your HIM department because they really need to look at your span of claims, first of all, falling into MDC-5. Diseases and disorders of the circulatory system is a very common MDC for Medicare patients, obviously. You need to look at your mix and what the consolidation does within your organization in terms of, are they moving into, are most of my patients moving into a higher weighted DRG, or are they moving into a lower weighted DRG? Because no matter what the change in the DRG base rate is, it is your mix of patients and the weights of those MSDRGs that is going to have a significant impact. So that's an analysis you should be doing right now as you prepare your comments and look at that regrouping that they have proposed. They are using a single year of data to set the weights for the MSDRGs, and again, no COVID modifications here. Something that has not, I don't think we've seen in a long time, but that relates to the post-acute the post-acute transfer policy, and that we are adding, or CMS is proposing to add, a number of MSDRGs to the post-acute transfer policy. The post-acute transfer policy, for those who are not familiar, essentially indicates that if a patient falls into this particular DRG and they are discharged to post-acute care prior to meeting the average length of stay for that particular DRG, they are considered a short stay patient, and there is a reduction in the DRG payment. Just so that you're familiar, I'm not going to read you the entire list of proposed MSDRGs that they are looking at, but just some of those that you need to take a look at is MSDRG 166, 67, and 68, which are your respiratory system OR procedures, and then obviously without major complications and comorbidities, or complications and comorbidities. Those are existing codes, but they are going to be slightly modifying the policy for those. New conditions that fall under the transfer policy are your appendix procedures, 397 through 399, coronary intravascular lithotripsy with intraluminal devices, again, a range of codes 322 through 323 through 325, I think. Those are all new and will be subject to the post-acute transfer policy. There was a table that was published as a part of the proposed rule that listed all of these, but I do urge you to take a look at it and then look at your transfers of those patients last year.
Yeah, Kathy, I don't understand why they call it a policy and not a penalty, because for most hospitals, the hit they take under the post-acute transfer policy is far in excess of any penalty they incur under any of the value-based purchasing programs.
Well, I agree with that, Marty, and I think the other issue is, shouldn't the patient be in the most appropriate setting?
Right, exactly.
And reduce the cost to the overall program. If the hospital is the most expensive setting, then they should be encouraging us to transfer to post-acute.
Right, and just as a shout out to my rural friends, the exception to the post-acute transfer policy is transfers to cost swing beds. They are not subject to this penalty, but a SNF, home health, hospice, all of those transfers are subject to the penalty. Of course, if the patient goes home early, which is always a good thing, you're not subject to the penalty for those. Okay. So last year when we talked about IPS, we talked a lot about strategies around health equity. In particular, as you may recall, CMS added a number of elements to the quality reporting program that related to a hospital's health equity initiatives. But this year, CMS actually puts their money where their mouth is by actually assigning a severity level designation to Z codes. Z codes are a manner in which to report certain social risk factors identified for patients. And there is a range of Z codes that correspond to homelessness. So if your patient is admitted, you do a screening for social risk factors, you identify that the patient is homeless, you would include on the claim a Z code to so identify the patient. CMS analyzes the data it has for claims with Z codes included on them and determined that the costs associated with caring for these patients is higher than you would anticipate for the DRG. And as a result, it has determined that a claim with these Z codes will be considered a complication or comorbidity. So it goes from non-CC, no payment adjustment, to complication or comorbidity with the CC. And you'll see there on the screen an example of the weights comparing pneumonia and pleurisy from a non-CC to a CC. It's significant. So this can have a significant financial impact for the hospital. And then you see a very long quote from the proposed rule where CMS says this is just the starting point. Homelessness was easy because it was the most commonly reported Z code, but we are hoping to see more Z codes on claims so we can do similar analyses to identify when we should be identifying a social risk factor as a complication of comorbidity that increased the cost of care.
That becomes one of those issues from a coding perspective. You're going to have to make sure that HIM is appropriately coding and indicating on the claim the homelessness, and that it is being captured at the point of registration as well.
Right. Yeah, it's the screening piece of it that you have to capture first. Right. Remember, that becomes part of IQR starting next year, is that requirement to do screenings.
On the issue of add-on payments, we'll start with the COVID treatments add-on payment. If you've heard our webinars related to the end of the PHE, you know that the add-on payment that you are getting for new COVID-19 treatments will expire at the end of fiscal year 2023, no payment for discharges after October 1 of 23. So that is not, it was mentioned in the rule, but it is not something that we can really comment on because this is done. But there is the issue of new technology add-on payments. And just as a refresher in terms of what are these things, a new technology add-on payment essentially is a new way of delivering care. In order to be considered for new technology, the technology has to be new, and it has to be not just new, but substantially it cannot be substantially similar to anything else that we have or that we are using to provide care to the patient. The new technology is going to have to be shown to be not adequately, the cost of the service is not adequately captured in the existing MSDRG to which it would fall. And it must also show substantial clinical improvement over existing products that are out there. So with that in mind, there are always a number of applications that are submitted for approval to CMS to be considered as an NTAP, and therefore as a provider you would receive an add-on payment for no less than 2 years, nor more than 3. But the add-on payments essentially have been a way to bring this new technology into the hospitals and for them to recognize its use. There were 39 applications that were addressed in the proposed rule, page after page after page of proposed applications. They are considering to continue the payment for 11 existing technologies and discontinue 15 that are no longer new. But on those 39 applications that were proposed, you've got to comment. If this is something, obviously the manufacturers will be commenting, but it also becomes an issue for some of the hospitals in terms of commenting on the proposal, the proposed addition of this as a new technology. There is a change in terms of the time period and the process for being approved as a new technology. Moving forward, the applicants are going to have to complete a FDA market authorization request. It must be completed at the time they submit their NTAP application, and they are also looking to move the FDA approval deadline from July 1 to May 1 because that allows a better opportunity for those new technologies to actually be approved by the FDA as we're going through this consideration process. And Marty, you had a comment related to AI.
Yeah, I went down the rabbit hole yesterday because there are a handful of devices that are AI enabled that have previously been approved for NTAP. And there's a couple in this round that are up for approval, one of which is an AI device that will detect seizures in epileptic patients. It's just, and this is part of the reason that CMS said we need more time, more upfront time to evaluate these applications for NTAP because we're receiving so many more, and because we're seeing with increased frequency these AI-enabled devices, and that certainly complicates our level of review. But you know, at HIMSS, the only thing people could say was AI this year, and clearly this is going to become, this is front and center in terms of incorporating these into processes in hospitals and having payment available to afford to bring these benefits to our patients. And it becomes, it's a workforce shortage issue, Kathy, because these AI-enabled devices can do a level of monitoring that allows you to expand the capacity of your nursing workforce. So it's going to be critical going forward, these types of debates. So don't ignore the 500 pages in the proposed rule that talk about add-on payments for new technology.
If you wait and read it once it's published in the Federal Register, it'll be shorter.
Yeah, exactly.
Not as big a print, but it'll be shorter.
Exactly.
If you're worried, same content, but on the issue of Medicare disproportionate share and uncompensated care reimbursement, I actually, looking at this, realized that we left one number off of this slide. They are proposing to reduce the payments for Medicare disproportionate share by $115 million, not a huge reduction, but this is essentially looks at the decrease in the number of uninsured within the country. We know that during the public health emergency, we had a number of individuals who were enrolled in Medicaid but are now going through redeterminations. And many of those individuals might become uninsured going forward. Gut feel, this might be something that is going to become an issue where they're cutting it this year. What happens next year or the year after when these people, actually it probably won't be until about 2026 or 2027 when we actually see the impact of these redeterminations, because they are using a 3-year average from worksheet S10 of the Medicare cost report. So they're using 18, 19, and 20 to measure the number of uninsured for this year. So what happens? It's going to be a while before we catch up with the fact that we've gone through Medicaid redeterminations and individuals would have lost their coverage. The formula for Medicare DSH is on the slide. It's something that we include just about every year, or as Marty said, this is the 3rd year we've included it. But it is your Medicare SSI days to total Medicare days, plus your Medicaid non-Medicare days divided by total patient days. Remember this formula because we're going to talk about the Medicare Safety Net Index in a little bit. And you can see that in this DSH calculation, the second number that you're looking at is Medicaid non-Medicare days. We do have those who are starting to look at this and say, why should Medicare subsidize Medicaid? Capital disproportionate share, oh yes, that's something distinct because as we talked about earlier, the capital rules are a little bit different than the inpatient rules. There has been this issue in terms of hospitals that reclassify, urban hospitals that reclassify as rural, and they have not historically been, they have historically been able to continue to receive their capital DSH payments. They are now proposing that effective for discharges on or after October 1 of 23, okay, I got it wrong. They will get DSH payments after October 1, 2023, because they won't be considered rural for capital purposes. They will be considered rural for wage index purposes. Got it? Did I do it? Got it, Marty?
So if they're not considered rural for capital DSH, that makes them eligible for capital DSH.
They will be, because moving forward, they will get capital DSH because they are urban hospitals merely reclassified as rural. So this, they identified that this is something that these hospitals should have, I don't want to say they should have been paid, but it was some provision in there they didn't catch.
Oh, that always sounds like something, a lawsuit to follow, right?
Exactly. But as Marty and I have been looking at what else is going on in the world, that $115 million reduction in Medicare DSH doesn't compare to the $8 billion cut in Medicaid disproportionate share that is expected to occur or is currently legislated to occur this year and for 3 years going forward. We do have bipartisan legislation that has been introduced in Congress that would delay. It won't be the first time we've had legislation to delay Medicaid dish cuts. We actually need legislation to stop Medicaid dish cuts. But we do have legislation, bipartisan, a number of states have been involved in this, that would delay this $8 billion cut, but just very concerning what this will do to a large number of hospitals. And it takes legislation, and we know where we are in the debt ceiling, or aren't.
Right. I mean, this is the advocacy piece to take away from today's webinar. These are the dish cuts that were included in the Affordable Care Act, because the concept was ACA would increase coverage, and thus it would not be necessary to have these dish payments to compensate hospitals. Obviously the can has been kicked down the road several times, obviously from 2010 to 2024. That's a heck of a can. But this is going to be the process to continue keeping this on the books and kicking it down the road, or do we end up becoming the sacrificial lamb in the debt ceiling debates, where in fact this moves forward? So it's a high risk area, definitely worth watching.
Last year, I think I predicted that this would go away. It didn't, and it's not actually being expanded or extended. We had a rule that came out several years ago related to low wage index hospitals. These are going to be hospitals in across the country that are below the 25th percentile in wage indices. So if your wage index is below 0.8615, you become a low wage index hospital. And what happens with those hospitals is that their wage index is brought up to half of the difference between their actual wage index and the 25th percentile. So if you're below the 0.8615, you're going to be brought up halfway between where you are and that 8615. This was applied in a budget neutral manner. So by implementing this policy, it was otherwise paid for under the base rate for all hospitals. So there was a slight decrease in base rate to pay for these hospitals to be considered to have this bump in the wage index. Well, even though the court, it was the DC District Court, found in favor of the hospitals who were not the low wage index hospitals, they were the ones who actually had that decrease in their base rate, and they argued that this was an inappropriate action on the part of CMS. Even though the hospitals won in Bridgeport Hospital v. Becerra, we are now in a situation where the CMS is appealing that court decision. The program was to have expired this year, but they are going to extend it through 2024 at least, because of other issues that delayed hospitals from actually benefiting from the bump in the wage index. This would be because of COVID, and those additional dollars that you received in this bump probably had to be used for a lot of different things, not necessarily wages. The idea behind the low wage index hospital program was essentially to give providers the opportunity to increase wages. I'm not sure that they were actually able to do that in the early years of COVID. They were more looking on patient safety, life safety code issues, things like that, isolation, building out their plant, otherwise using those funds.
So they couldn't break that crazy cycle of you're paid less because you have low wages, so you can't pay higher wages, so you continue to be paid less because you have lower wages.
It is one of those, I think MedPAC uses the term, the circularity of the wage index. Those that have, and those that don't. And it's hard to move from one to the other.
Kathy, more wage index, please.
Yes, and then I'm going to turn it over to you for a little bit. Under the wage index, I think we have something on this particular issue of who goes into the rural wage index and who doesn't. We have this every year. So there is a proposal that would treat rural hospitals that have reclassified. They are not truly rural. They are urban hospitals that have reclassified as rural, the same as those that are geographically rural for the purposes of the wage index. As of last year, there was regulation that counted those reclassified hospitals in calculating the rural floor within a state, which is the overall, the lowest, the wage index, statewide rural wage index is called your rural floor, but it was not used in calculating the rural wage index. So now they are saying not only would we use it for calculating the rural floor, but also the rural wage index within a state. This will increase the wage index of many rural hospitals because you are taking an urban hospital and what they pay their staff, and you are adding that into what the rural hospitals within your state pay. So I guess if you start playing with the rules, and maybe we should do something on this one day, Marty, if you start playing with who gets reclassified, if I am a large urban hospital that has a lot of satellites, one of whom is in a rural area, but I am a single facility, I can look at reclassifying as rural. So now I have my large urban academic medical center that just became rural because I have a rural satellite that's under the same provider number.
And so all the other rural PPS hospitals in that state benefit because the higher wages in the academic medical center now are worked into the rural floor.
Exactly,
Cool.
but it is cool for the rural hospitals, but remember this has to be done budget neutrally.
Exactly. Winners and losers every single time when it comes to
Right.
the wage index. I mean, that's the whole story of the wage index because it's how we divide the pie. And the pie is the pie, right? It's just how we slice it is what we do with the wage index every single time.
The typical reclassification under section 412.103 of the Social Security Act, essentially there has been a provision where there are some hospitals that have reclassified two different ways. One through section 412.103, which is going to be that urban to rural, and have also done a Medicare Geographic Reclassification Review Board reclassifications. They are now saying, wait, these dual reclass hospitals, we aren't going to include them in the rural wage index calculation. So this is going to be only those hospitals that have dual reclassifications. They are going to be excluded from calculating the rural wage index. Other than those hospitals, everyone who is considered rural, whether it is geographic or reclassified, will go into both the rural wage index and the rural floor. Marty.
Let's switch gears. Let's talk quality. So inpatient quality reporting program, it doesn't matter how you perform on these measures. It's the fact that you report data on these measures that impacts your reimbursement. Failure to participate fully in the program results in a 25% reduction in your market basket increase. Kathy showed you those percentages for FY24 going forward. Remember, this is always a 2-year drag. So the adjustments to be made in 2024 are actually based on performance in FY22. We know that we have about 95 hospitals that are going to be penalized for failure to report under IQR in FY2022. You see here on the page a summary of the additions that are made, so new measures to report on. These will come online with the calendar year 25 reporting period. You see adjustments that are made to existing measures. Note in particular the COVID-19 vaccination among healthcare personnel adjustment, changing the language from complete vaccination course to up to date with their current vaccines, i.e. the bivariate having the bivariate shot can in fact satisfy the requirement as opposed to having all the predecessor shots before it. That will become effective at the end of this year, Q4 2023. So that's an accelerated change in the IQR program. There are 3 measures that are coming out of the IQR program. And then some changes to the data submission, particularly around HCAHPS, new ways that the HCAHPS survey could be distributed starting with 2025 discharges, as well as some targeting exceptions, targeting criteria changes for hospitals around extraordinary circumstances exceptions. Regarding the Promoting Interoperability program, if you fail to participate in PI, you're looking at a 75% reduction to your market basket update. So instead of that 3% that Kathy talked about, you're going to get only 75, you're going to get 25% of that as your adjustment. Again, for reporting period, so performance in 2022 results in 164 hospitals that will be penalized for failure to participate in PI fully in 2022. Those penalties to be assessed in 2024. This year, relatively minor adjustments to the PI program. They define this the calendar year 25 reporting period. They now require that you attest yes to having completed the self-assessment on the SAFER guides. Previously, it had simply been that you didn't have to report yes, you did it. You simply had to report whether you did it or not. But now the score will be based on whether you respond yes. And then also we, of course, have new ECQMs, as we always do, coming online that you can select for one of your 3 self-selected ECQM, reporting requirements. Moving to our value-based program, starting with the Hospital Readmission Reduction Program. So this program compares 30-day risk-adjusted standardized, unplanned admissions among hospitals with a similar proportion of due eligibles. So this was our first measure that got health equitied. Because we used to compare all hospitals and determine who would be penalized. Now you're put into 5 buckets based on the number of dual eligibles that you've served, and you're compared to those hospitals. It is not across all readmissions. It is only certain conditions or procedures. You see them listed here. Circle pneumonia, because during COVID, pneumonia had been accepted out because of its frequency, the frequency of reporting around COVID and using pneumonia DRGs. That is not, it will go back to normal pneumonia for FY2024. There are no proposed changes to methodology of how we calculate this or the like, but this is a significant penalty. The worst performers, it's a sliding scale, worst performers face a 3% reduction in their DRG payments, but really 2,900 hospitals will bear some penalty because of their readmission rates. Almost 85% of the hospitals that are measured under the readmission program are penalized in this program. Again, it's CMS constantly pulling attention to this issue of how are you managing patients post-discharge and trying to create that incentive system to ensure that we are managing those transitions appropriately. The Hospital Value-Based Purchasing Program, which I refer to as the Robin Hood program, because we hold for all hospitals, there's a 2% withhold on their DRG payments. And that 2% withhold for all hospitals goes in a pool. And that pool, which will be about $1.7 billion in FY24, is then redistributed based on level of performance across the measures and value-based purchasing program. And it will actually be redistributed this year because again, during COVID, everyone got their 2% back. So now going forward, that money will be redistributed based on performance on the measures. In terms of the measures to be included, we'll be adding the severe sepsis and septic shock management bundle measure, with CY24 being the initial performance period. we're adding a new health equity adjustment bonus payment to the total performance score. So this is going to provide you a kicker depending on how well you perform on measures with the individuals, with dual eligible individuals. So again, this is intended to raise up your score if you're treating a more challenging population, which we use dual eligibles as that measure, since we don't, at least at this point, have a better way of identifying those high-risk patients. We'll talk in a minute about the RFI and additional program changes to address health equity. So if you have comments around the value-based purchasing program, how it can make it more fair depending on the population you serve, there's a request for information there. And again, other modifications made to the program, they're going to be impacting later performance years. My favorite acronym in healthcare, the HACK program. Can't beat that one, can you?
You did that so well.
I thank you. I practice every year. The Hospital Acquired Condition Reduction Program. This is where it's a bad thing to have the highest score. The highest score being the highest rate of hospital acquired conditions. You see there the specific 6 measures that they evaluate to calculate the overall HACK score. If you are one of the hospitals that's in the top quartile, however the numbers end up, you're going to get a 1% penalty withhold on all of your Medicare payments.
And Marty, I think that's a key to the HACK program compared to value-based purchasing and readmissions. Readmissions and value-based purchasing impact your DRG payment, the actual weight times the rate. For the Hospital Acquired Conditions program, it is your total payment, your disproportionate share, your teaching, all of those add-on payments that you get because you are a particular type of provider. Those are also subject to that 1% penalty.
Yeah, and again, it's similar to the value-based purchasing program because it's the worst quartile. So you could be improving your performance, but if everyone else improves even more, you still find yourself in the penalty.
There will always be a bottom quartile.
Right.
Even if we're all at 99%, there's still a bottom quartile.
Yeah. It appears CMS is getting a little bored with these measures because they've included a request for comment on future measures that would both advance patient safety but also reduce health disparities. So here's your opportunity if there are other hacks that you think we should be evaluating. There's a new data validation process. It is similar to what we do with the inpatient quality reporting program and how you validate your data before it is actually analyzed into the system. That will begin with impacting this calendar year, last year, calendar year 22 discharges. So you'll have that opportunity to review your data. And then we're modifying the targeting criteria for data validation to include those hospitals that receive ECE adjustments. That will not start until fiscal year 27.
One thing on the VBP HACK and readmissions program, the Medicare Payment Advisory Commission has been looking at creating a revised value program for hospitals that essentially combines everything. So that will be something that we will be reporting on as we move forward and we see their proposals.
It will be interesting to see the implementation timeline on something like that, because these programs all took, a good 3 years to ramp up. They were all, with the exception of IQR, these all again have their genesis in the ACA,
right,
and came online and have been revised over the last decade. So we're getting used to them. It will be very interesting to see how you readjust this. So. The big request for information in this proposed rule regards safety net hospitals. As a very broad request for feedback from CMS, we want to know what your challenges are as safety net hospitals, and we know how we can better help you meet those challenges. The first piece of that is, who are safety net hospitals? And what should we use as the definition to identify and categorize safety nets for policy purposes? Kathy, you take over. I need the coffee real quick.
Sure. the Medicare Payment Advisory Commission has just recently released in their March report this discussion of the Medicare Safety Net Index, the MSNI. And I talked about it when I gave you the formula earlier related to Medicare disproportionate share, and we're looking at your Medicaid patients who are not also Medicare patients. That goes into measuring Medicare disproportionate share. MedPAC is saying, and they are an advisor to Congress in terms of how dollars should better be spent. We're also looking at where are we with the trust fund. They're saying that high Medicaid hospitals who are not also Medicare, large Medicare hospitals, should not be getting this add-on payment for Medicare disproportionate share. The funding should come through Medicaid. Meanwhile, we talked about we're getting ready to cut Medicaid if we can't find a solution for that. But the argument is Medicare is in trouble. Medicare doesn't have a lot longer. Marty, I think you get 1 year, depending upon what happens. But the issue is, should we be using Medicare dollars to fund Medicaid, predominantly Medicaid hospitals when the patients aren't dual eligibles? So it becomes an issue that they're asking for comment on, feedback on. I can see us going obviously both ways on this. And so when we talk about comments, we say, make sure you comment. I would definitely make sure I have my voice heard on this.
I mean, the bottom line is they want states to contribute, right? So if we say it should be Medicaid, it should be the state proportionate share, should be funding the support for these safety net hospitals. Is that pretty clear? This other alternative that they talk about in the proposed rule is the area level indices. This is a model they're using within the ACO REACH program to identify, again, high risk patients for purposes of adjustments to quality scores under the ACO REACH program. But they also float here whether this would be an appropriate tool to identify safety net hospitals. But then they just say, here's a lot of things we want you to comment on. Are there specific challenges that rural safety net hospitals face that are unique from urban safety net hospitals? What are your challenges around IT investments? Are there new ways or approaches to address your identified challenges that you suggest? Should we subject you to different reporting requirements? Should we have like a modified IQR, for example, for safety net hospitals? Should we otherwise treat you differently under the value-based purchasing programs that we have in place? How can we better help you, CMS says that, on managing patients once they're discharged from safety net hospitals? Because we're assuming these are the higher risk patients. These are the ones more likely to readmit or have other health challenges following discharge from the hospital. What are some appropriate programs to implement there? And then finally, should we be standardizing financial assistance policies? As opposed to every hospital developing their own, should we be developing some sort of index for safety net hospitals to have some version of financial assistance policy? So it's pretty wide open. If you are one of the safety nets,
read the comments on that.
Yeah, it's going to be really interesting. But it's great that CMS has identified this as an issue to call out in a different way than simply saying, oh, you're a DISH or a UCC hospital. Let's call you what you are, which is a safety net hospital. Okay, things they didn't talk about, or did a little bit, but not a lot. Sorry, just a second. Oops, I went too far. Sorry, my bad. There we go.
I'm going to start off and then I'll turn it over to Marty. But we all know that in the inpatient proposed rule, we also have a major section on long-term acute care hospitals, and they have a proposed update as well that is included in this rule. They did include, the main thing I want to focus on here is that they did propose an increase in your rates of 2.9%, but overall the payments to LTACs are expected to decrease about 4.7%. This is based upon the proposed rule. Why? Because of outliers. Remember I mentioned about a $2,500 difference between the current outlier dollars for inpatient acute versus proposed. What they are proposing to do for long-term acute care hospitals is to increase the cost outlier, the high cost outlier threshold from $38,518 to $94,378. Huge. And the impact on a LTAC receiving outlier dollars, huge decrease, because you're going to have $60,000 more, almost $60,000 more in cost in order to get paid as an outlier on these particular cases. The reason for this adjustment is because there is a statutory requirement for the cost outlier pool. It is set at 7.975%. Interesting, because acute care hospitals are quote unquote between 5 and 6.
That's a little more precise, isn't it?
Yeah. 7.975 is what the pool has to be set at. So recognize that to maintain that pool, they are saying we have to increase the high cost outlier threshold by close to $60,000. They are also making changes to the quality reporting program for LTACs. And Marty, what about rural emergency hospitals?
Okay, Kathy, I think I've calmed down over this issue a little bit, because this new provider type, rural emergency hospitals, that CMS is standing up, which is the outpatient only hospital in rural communities. The program initiated at the beginning of this year. The last CMS official I heard talk about this said there have been no hospitals yet approved for REH conversion, but in the IPS rule, CMS proposes a methodology for GME payments to REHs that provide training sites, which all the other issues around the REH program, and this is what they decided to focus on. But then I reminded myself that in fact CMS has been addressing the REH program in the outpatient. And so hopefully we will see other improvements or enhancements to the REH program to make it more viable in that rulemaking process. Boy, CMS does not like physician-owned hospitals, as is apparent when you read the provisions in the proposed rule regarding their changes in the process for physician-owned hospitals to receive an exception from the Stark Law prohibition on any expansion of their facility. It used to be a much more straightforward process. If you had a physician-owned hospital and you wanted to add beds, or you wanted to add a department to it, expand the physical space, expand the service offering, it was a relatively straightforward process you went through with CMS to accomplish that. They are certainly going to make that a much more onerous process if this proposed rule is finalized. So if you, however your opinion is on physician-owned hospitals, there's an opportunity for comment to CMS on this point. There are some changes to the PPS exempt cancer hospitals, all 7 of you out there. There's some changes to your quality reporting program. Interestingly, no changes to conditions of participation. And I mean, CMS uses different vehicles to propose and finalize changes to hospital and other provider conditions of participation, but it is frequently the IPS rule that serves as that vehicle. None proposed right now. And finally, there's just not much of anything about the end of the PHE. We had been hoping, I think, Kathy, against hope, that some of those waivers and flexibilities that had served us well for the last 3 years may find their way into permanent policy through this year's rulemaking. I think we'll be waiting for the 2025 rulemaking to actually see those opportunities as CMS will let us go forward and unwind. On the issue of the end of the PHE, if you're an HCR frequent listener, you know, Kathy and I have done a couple of webinars on the end of the PHE. PYA has produced a checklist that goes through the changes that will take effect on May 11th and thereafter. Just a note that following yesterday's CMS Open Door Forum on the end of the PHE, there will be a number of updates we're making to that checklist. Hopefully that will be posted to our website later today. CMS has promised to post the transcript of that call, which was really exceptionally good. I thought they did a great job on that, addressing some key issues. So we've made those updates as well. Kathy, here, it's time for your official plug.
Yes, as a reminder, comments are due June 9th. Ignore the original slide. And we've given you the address to submit your comments on and the reference number, CMS 1785P. Remember, first of all, don't just assume that someone else is going to comment for you. Don't assume that a national association or a state association is going to cover your issues, because you might have a different opinion than the guy down the street who benefits and you lose, okay? So comment on what's good, what's not. Just submit comments. Seriously, if you support something, tell them you support it.
Yeah, I mean, when you've got budget neutral provisions, there's winners and losers, and an association has a hard time advocating for winners and losers at the same time. So,
Right.
As Trevor said at the beginning, we've scheduled an hour and 15 minutes for this webinar. So this is the extra credit portion of the show. So if you can stick with us for the next 15 minutes and understand completely, if you've got other things to do, or if you just don't really care about Medicare Advantage, you may not want to stick around. But we thought that these 3 final rules deserve some extra attention, specifically how they're going to impact providers going forward. So we tacked on this extra 15 minutes to today's webinar to address these topics. So thank you if you're leaving now. Hope we were helpful on the IPS front, but if you're sticking around, let's talk about MA, because it has been busy in terms of rulemaking around MA. The first is a final rule published in February called the RADV final rule. RADV is Risk Adjustment Data Validation. This is the process CMS uses to ensure it does not overpay MA plans. Remember, payments to MA plans are based on the risk within their population. So the individuals who have subscribed to their plan, CMS evaluates the risk in that population by looking at what diagnosis codes have been reported for those individuals, which generate HCCs, which generate risk factors. So this process is to ensure that MA plans are not improperly upcoding to get higher payments from CMS. CMS plan is to audit about 5% of plan contracts each year for this purpose. What they do is select a random sample of enrollees, and the plan is then responsible for producing the medical record to support the listed diagnoses for those individuals. What's happened historically is that the overpayment demand from CMS has just been on those enrollees whose records were reviewed. In the final rule, CMS says, beginning with our audits of plan year 2018, we're going to extrapolate those results across all plan enrollees. So beginning with audits likely to start in 2025, CMS will apply a yet to be fully announced extrapolation methodology where it will focus on those plans it believes to be the highest risk of overpayment through statistical modeling and data analytics, and will review those plans. So let's say they find a 5% error rate, that 5% of the time the reported diagnosis code wasn't supported by the medical record. They're going to apply that 5% across the entire plan membership. So that, of course, means much more significant opportunities for payback. The plans did not like this. They commented extensively on this, but still CMS held firm and published this as a final rule. What's it mean for providers? Well, if the MA plans lose money, then they're going to be looking to providers and the payments that they made to those providers and potential clawbacks. If you are a provider, for example, that has a risk-based contract with an MA plan, it is likely you will find clawback provisions in that contract, which address that if there's a change in the payment made to the MA plan, that results in a change made to the provider. So you certainly want to be attentive to this. It certainly means that CMS is going to be policing more actively providers' diagnosis code accuracy. For example, if you're participating in one of the value-based programs like MSSP, ACO REACH, BPCIA, that coding, diagnosis coding, informs the benchmark. And if the benchmark is artificially high, that means you're receiving improper payments under those value-based programs. So this is certainly an area that's going to get a lot more attention going forward of how we measure patient populations. In fact, the 2024 rate announcement that came out in early April, the plans went from a promised 1.1% payment increase, that was in the proposed rate announcement in January, to what is a 3.32 payment increase, which is about $13.8 billion extra dollars going into the MA program. Where that dollar change came from, for the most part, is how CMS chose to phase in its new risk adjustment model. So CMS has been using a 2020 risk adjustment model. So the data it's been relying on to drive its risk adjustment model comes from 16, 17, 18. What it had proposed was a significant update to that model for 2024. It would map to fewer ICD-10s, so you would have a fewer number of ICD-10s that would have a payment impact and thus be calculated into the HCC. And they rebuilt the HCCs, so they ended up with a different number of HCCs, but they weighted them differently. So we used to have, for example, or there is today in the 2020 model, a significant difference between the HCC for diabetes with complications and diabetes without complications. One of the things that happens in this 24 model is that that becomes one HCC. There's no they no longer distinguish between the two. On their idea that the complications will instead be accounted for in other HCCs assigned to that patient. So there's some pretty significant changes ahead for this. Because of the pushback from the plans, CMS chose to do a 3-year implementation. So this year, the risk adjustment will be based 1/3 on the 2024 model, 2/3 on the 2020 model, then the flip of that in 2025, and then fully over to the 2024 model in 2026. So significant changes coming that way. The other piece I can't figure out the answer to, at least at this point, and if anyone knows, please let us know, is how will CMS implement the 2024 model in its own alternative payment models? For example, in the MSSP program, if you read all the detail on how they calculate benchmarks, they say we will use the MA risk adjustment model. Well, now that the MA risk adjustment model is being updated from 2020 to 2024, are they going to phase it in a similar way for MA in these other value-based programs? But either way, if you are participating in those value-based programs, appreciate the work you've been doing around diagnostic coding, accurate documentation, all to make sure you're accurately reflecting the risk in your population. But there's going to be some changes here as we recalibrate the HCCs going forward under this new model.
And Marty, there is an open door call tomorrow, a rural call. Might be good to submit that question to CMS.
Okay. I'll do it. And then our third rule, the April 23 final rule, has some pretty significant impacts on MA plans. And again, these roll down to providers, specifically around plans use of prior authorization, utilization management, the substantive elements of prior authorization, the procedural elements of prior authorization, like how quickly they have to act on a prior authorization. That's actually been the subject of a separate proposed rule that has much broader impact. So it would apply to Medicaid MCOs and commercial plans on the exchanges and the like. That proposed rule is still out there. The comment period ended early this year. Last time I checked, Kathy, nothing on in OMB on that rule, right? But these are the substantive changes that apply to MA, is what we're discussing under this rule. New provisions regarding health equity, changes to behavioral health, specifically around network adequacy, and then plan marketing restrictions. Note here, if you participated in our webinar back in January when we were going through all these proposed rules that came out over the holidays, Kathy was jumping up and down about a provision in the proposed rule, it's the proposal that then became this final rule, because there were proposed changes on how you characterized overpayments and providers' obligations to identify and return Medicare overpayments, changing the standard going forward, which certainly would have had a significant impact on compliance programs and how they approached internal auditing and how they engaged with the MACs in returning what they had identified as overpayments. Thank goodness CMS realized that was a big can of worms they were about to open, and they note in this final rule that they've deferred that to separate action at a later published rule. So maybe it will attach to the prior authorization rule.
Hasn't gone away.
Hasn't gone away, but it's not here yet, I guess is the way to put that.
Right.
Briefly, let's run through what they've changed on prior authorization. I mean, the reason for doing this is stunning. This all comes from a report that was published by Kaiser Family Foundation, KFF. They looked at data from 2021, and that data covered 87% of plans. And there were 35 million prior authorization requests submitted. Of those, about 2 million actually resulted in denials of payment. When they were, very few of those were appealed, but when they were appealed, the provider was successful 82% of the time. I mean, those numbers show you that there's something going on in the utilization of prior authorization requirements by MA plans for price control purposes. We'll leave it there. But certainly there's been some aggressive, we'll call them aggressive practices by MA plans of requiring prior authorization. So these substantive requirements, we now know that MA plans will be subject to national coverage determinations, local coverage determinations, as well as just the general coverage rules within Medicare statutes and regulations. That includes coverage criteria for different types of admissions. Specifically, CMS called out that admissions that relate to surgeries that are on the inpatient only list, MA plans have to cover those as inpatient admissions. Pretty straightforward. It's a little more involved when you get to the issue of the 2 midnight benchmark. They have to follow the benchmark, but they don't have to apply the presumption. So the presumption is the auditing tool that CMS uses with its MACs. It tells MACs to assume that if they cross the 2 midnight threshold, that is not an inpatient admission that warrants review. They're not holding MA plans to that standard, but they are holding them to the benchmark. That if the physician determines that the case is of sufficient complexity that it will require at least a 2 midnight stay, that is deemed coverage for an inpatient admission, now MA plans will be subject to that. That is fabulous news. And these become effective June 5th.
Let me jump in on that one. I know we're getting short on time, but I want to just jump in. When I look at who's registered for this, we got a lot of finance folks and others, but that first little bullet right there and the 2 underneath it, you need to get to your case managers, your QA team yesterday, because as they are dealing with patients from these plans, they need to be aware that it is no longer a separate policy for the plan as opposed to following the NCDs, LCDs, and those general Medicare coverage guidelines. It's huge.
And CMS really reined in MA plans' ability to publish their own internal coverage criteria first, and importantly, it has to be public. They can't apply it unless they've publicly released the criteria. And then they've also established standards of evidentiary support for any implementation of an internal coverage standard. So these are great victories across the board for providers with regard to PA practices. They also mandate that plans establish a utilization committee, a utilization management committee that's run by the medical director. They have to review all of their policies and justify them on an annual basis. And also prior authorizations must remain valid during the course of treatment with appropriate provisions of a 90-day transition period when a beneficiary changes coverage. On health equity, CMS is now implementing a star rating health equity index. It is going to look how well plans perform among individuals with specified risk factors. This will replace the reward factor for consistently high performance, or what we call the 5-star kicker, because a lot of plans that made it to 5 stars were only making it because of that reward factor. But now we're eliminating that reward factor and replacing it with the health equity index. And then the initial group of social risk factors we'll be looking at are the low income subsidy for Medicare Part D, the dual eligibles, and individuals qualifying as disabled for Medicare purposes. We'll be looking at this into the 2027 star rating. Several other health equity related plan requirements, just to make sure you're not alone, appreciating the plan that CMS is looking to the MA plans also to be a critical part of this equation. A number of changes on behavioral health in terms of plan adequacy. Previously, we had only included psychiatry and inpatient psychiatric facilities as network adequacy requirements. We're now adding to the list social workers and psychologists. And you see there the different requirements in terms of network adequacy, and very important, they have clarified that emergency medical condition includes both physical and behavioral health conditions, meaning applying the prudent layperson standard. If it's a behavioral health emergency, there has to be coverage without any prior authorization. And then finally, maybe if the slide will move, last but not least, a number of new plan marketing restrictions. I just couldn't resist the temptation of just covering them here, copying the list here. But there are 22 new requirements and limitations on plans with regard to their enrollment activities. Unfortunately, one of them is no longer used Joe Namath.
Yeah,
No Joe Namath provision,
his
right?
name isn't there anywhere.
His name is not there, but they can continue to use Joe Namath as their person. But these will apply for this fall's annual influx of calls on MA plans. We will conclude there. Just highlight for you upcoming HCRRs. 2 weeks from today, Kathy and I are going to do the No Surprises Act. There's been lots going on there, and it's time for an update. And then our colleague Susan Thomas will take you through a HIPAA update on May 24. Hope you'll be able to join us then. Thank you to everyone that stuck around for the extra credit, and hope you have a great week. Kathy, anything else to add?
I think we did it, but submit comments on that inpatient.
I knew she said that.
Yes.
Great. Thanks so much.
Take care.
Thanks to our presenters, Martie Ross and Kathy Reep. Later today, you will receive an email with their contact information and a recording of the webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website, www.pyapc.com. While at our website, you may register for other PYA webinars and learn more about the full range of services offered by PYA. Please remember to stay on the line once the webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you for joining us and have a great rest of your day.